through it really well, but I'll just mention something about it. I was trying to go offline and didn't work. So I'll mention somewhere so that at least we place where intervention studies come into this picture. I'll talk a little bit about experimental study designs, focus on randomized controlled trials, which is the main thing that we really need to talk about. So I'll place them within experimental design so that you understand where we are coming from. Then I've had, while I'm here, a lot of talk about bias and confounding. So I'll ask a few questions about bias and confounding. Rather than me saying it, I'll ask you. So I've sort of, I was debating whether to remove those slides completely. The T confused me. So let me go back a little bit and talk about research. I don't know how many of you, when you're small, when you are talking about research, you only knew, I don't know if pointers work, you only knew about this end of things, experimental. That's what we knew when you were kids about research. Research was about mice and what you can do with mice in a lab, cockroaches in the lab when you're in primary. So everything Jeanette has talked about, that came later in life. So I'm talking about the more exciting things, right? What we knew as research. But over time, the observational end of things has come to be really important in our understanding of what we do with healthcare. And we won't talk too much about ethics, but ethics is one of those big things that comes into picture when you're talking about research and pushes you more into observational for some things and not go into experimental designs until you're sure that it is safe to go experimental. But anyway, you've already talked about case controls, case reports, cohort studies, all those things. So I am on the other side of experimental. We are no longer observing. But just before I go there, let's discuss a little bit. So my first question, we think, just randomly, the same way you guys were talking about penile length. I don't know who chose penile. Anyway, we think oropharyngeal cancer, let me be more, things that you can go home and say you learned something. When you go home and you talk about what Jeanette was talking. Okay, we think oropharyngeal cancer is associated with the use of certain types of pesticides that were used 20 years ago. So which type of study can you use to assess that? Yes? Aki, you're not purity, certainly. You are right, that's why I'm pointing at you. Yes? Boru. Case control. Yeah, so a case control study is very nice to answer this question, right? Where the cases are the people with, in chorus? Oropharyngeal cancer. And the exposure is the pesticide of interest, and the pesticide is no longer in use. So the case control study will answer this very well. Okay, based on the proportion of adults aged 40 and above in Kenya, 40 and above with hypertension, we estimate about half of this class, you people seated here. We estimate that this is hypothetical, by the way, before you start getting depressed. So this is hypothetical. We estimate that about half of the participants in this class will develop hypertension in the next 20 years. Which study design can we use to assess the predictors of hypertension in this class? So in the next 20 years, we think half of you will have hypertension. Hypothetical, please do not tell the pastor I said this. Anyway, which study design works well for this? A cohort. Retrospective cohort, I had you even know retrospective. Prospective cohort. So we'd follow you as a cohort and assume that the exposure is perhaps the mandazis you've been eating. So a prospective cohort is good for this. Both of these questions that I've just given you are not good for a clinical trial, right? We cannot use an experimental design for any of those. One of the antibiotics that was commonly used in the 60s but we don't use it much today, has been shown to reduce the chance of developing malaria when used daily for 2 weeks in a rural community in Thailand. Again, it's hypothetical. Msiandike kwa gazeti ama social media. What study design can we use to assess if this strategy can work in Kenya? Case control, where cases are. Okay, so let's think about the case control. So the case is the outcome of interest is malaria. The exposure is an antibiotic. Is the antibiotic used currently? So how will you get the exposure? We'd have to administer the antibiotic, right? If you administer an antibiotic, can you use an observational design? No, because you have intervened. So see, I'm trying to get you into my wording. So if you're intervening, it is an interventional study design. Interventional study designs, any that you know? RCT. Umefika kwa RCT. Now you're in my topic. So malaria is a good thing to use an interventional study for because malaria is something that comes fairly quickly. You can enroll people fairly fast. And you're doing an intervention because I've just told you this antibiotic is not being used. So you'd have to administer the antibiotic. So whereas the first two, we cannot do an interventional study. We certainly cannot do an interventional study around oropharyngeal cancer because it will take years before we get anything. I mean, in terms of looking at the exposure to pesticides, we cannot do much with regard to hypertension in this class with an interventional study because we are talking about 20 years from now. But for this one, an interventional study is a good study design. So right from the onset, we're already saying that an interventional study is not always the option that we will take. However, Jeanette just gave you this in a different slide, so I'll put it up again for us to just quickly recall that as far as interventional studies or experimental study designs are concerned, when you look at the pyramid of evidence, they are up there. The least evidence that you can have for any research is expert opinion. You know, the way, I'm told there are a few doctors here. You know, the consultant who walks around the ward and has all the knowledge. That is the least level of evidence. It feels nice when I say that in the University of Nairobi. So that's the least level. Then you go to your case series and case studies. The way COVID, when it started, you know, people just started putting out, I saw this patient and this came with this and this and this, and then someone else in China writes something different, someone else in Singapore writes, and then Americans write, Kenyans come and write something different. So you're building a case with case studies. And when many case studies are put together, it becomes a case series. We have seen 15 cases of Mpox across East Africa so far, and this is the symptom complex that you're seeing within East Africa. Then you go on to cohort studies and your case controlled somewhere up there, and then once you start intervening, then the level of evidence that you're generating is really important in terms of policy decisions that we're even making for the community. So I'll talk about non-randomized and randomized control trials at some point. Jeanette introduced the critical appraisals that we can have beyond the clinical trials, all the way to meta-analysis that really is at the pinnacle of evidence generation. Okay. So again, not to go too complex. I've heard you guys talking about exposure and outcomes since I came. What is an exposure in your own words? So someone who's not purity. Okay, I don't know who purity is, by the Someone wants to gather to just hazard in their own words. What is an exposure? Haki mmesema so many times. Yes, sir. An exposure is a risk factor. Good, that's a place to start. A risk factor for what? Someone else can build? For a cause. A risk factor or a cause of an outcome. Hey, you guys you're a team. Good. So the sentence has been made by you as a team. What is an outcome? So now that we have a risk factor or a cause of the outcome. The outcome is? Okay, now the only problem this time you're saying different words, so I can't quite hear well. You smiled when I said purity. Are you purity? Yes, purity. Expected result. Someone else? Mongea. Someone else? There are many answers. No answer is wrong, by the way. An event of interest. A condition. Desirable effect. Okay. All right, so many words used. Okay, so let me use my own words. So an exposure, as you said, is a variable or a factor that we think. Now, I'm changing your words slightly. I'm not saying that it causes, neither am I saying that it is associated. I'm saying that it may. And this is important in interventional studies. In interventional studies, we many times do not quite know for sure. That's why we are doing a study. So it may, sorry, I'm in the university and I'm saying may and I'm remembering that lecturer for calling a strike. It may or may not. Okay, so it may. It may affect the outcome of interest, either positively or negatively, right? Yes, underline the word may. Good. All right, I think we all know who we are talking about. All right. Exposure, on the other hand, the outcome, on the other hand, it's the disease, the state of health, the event, and in many cases, we even use death as an outcome of interest. Notice that when you come to outcome, we do not yet know the direction. We do not know if it is the desirable or if it is, if it will happen for sure. But this is, there are some words that were used that made us think that an outcome is something that, we truly are not anticipating. We, of course, know it will happen. But the outcome is basically that thing that you define, as we've said severally. Interchangeably, you'll hear people talking of dependent and independent variables. Has anyone heard those terms? I've had a yes somewhere. Dependent variable, what is it? The outcome. And the independent variable? Good, the predictor, the exposure. So there are many words used for the same, but consistently with the previous lecture and with what you've already done, I'll keep to outcome and exposure. So, but it's important to have that in mind. Okay, so just for all of us to be on the same page, again, for the three cases that I talked about, the outcomes are in which color? It helps me know. That helps me know that you can see the slides. And the exposures are in which color? Wow, okay, red. I was expecting some shades of red from the female voices. Yeah. So why we want to always define exposures and outcomes is that it is important in us understanding what design we are using. We've already talked about some of this. The cross-sectional design, you are looking at the exposure and outcome at the same time. And that's why, for instance, you are discussing the issue of you don't know which came first, the exposure or the outcome, but you're saying that the exposure and the outcome are present at the same time. The case control, on the other hand, starts with the outcome, and your direction is backwards. You're going to look for the exposure in the past. For the cohort studies, the prospective cohort, which is the commonest type of cohort study, you start with people with the exposure and those without the exposure and follow them over time to look out for the outcomes. And you'll notice that that is the same direction that we take with clinical trials. Clinical trials will mirror how you'll do the cohort, except that there is an intervention that we do. Okay, so let me go to my topic, experimental study designs. So experimental study designs, I had you talking about the null hypothesis. So they test the hypothesis by manipulating one or more of the exposures that you have, and then looking at what that manipulation has in terms of the effect on the outcome. So that is really important because it helps us to establish the cause and effect. So basically, it's a design that allows us to say, if I give this drug, does it stop malaria from occurring, or does it do nothing in terms of the incidence of malaria? So it helps us to establish a cause and effect, and ultimately, in anything that we do in research, we are trying to look for causality. We are not yet at causality in clinical trials, but then we are trying to work towards that journey of figuring out, does cigarette smoking cause lung cancer, for instance? Does use of diapers affect penile length? That is very interesting. Okay, so now the thing though is that because we're really looking for the effect of a particular exposure to the outcome, we have a controlled environment within which we do the work. So there's a high level of control of the conditions of the study. And the controls are trying to minimize as much as possible other things that may affect how the exposure and the outcome affect each other. And so for this, there are many designs that you can use. The cornerstone is the randomized control trials that we'll be talking about. It's like the gold standard of experimental design, especially in the settings that we are in, mostly in healthcare provision. But you can go to other designs, field experiments, which are more about looking at the natural setting and what the effect of the intervention on the outcome within a natural setting as opposed to a lab setting, for instance. And so, to some extent, clinical trials also within pharmaceuticals would fall there in some definitions. You can have natural experiments where you truly are not controlling the intervention, but the intervention is happening in one place versus vis-a-vis another, naturally occurring, and you actually follow that up. And a quasi-experimental design, so a quasi-experimental design is where, for instance, you are not able to randomly assign the intervention to the participants in the study. So you're almost at experimental, but at randomized control trial, but you can't because of factors that are beyond yourself. But let's stay with clinical trials. Clinical trials, randomized clinical trials, really are the cornerstone of where we are in terms of evidence generation. And basically, in a clinical trial, what we do is that we prospectively assign an intervention, one or more interventions, to the participants who come to the study or participate in the study and look out for the outcome. So your interventions are many. It could be drugs, it could be biological products, it could be surgical procedures, It could be radiological procedures, devices, many things. The intervention that you're coming up with and looking at what the outcome is. So in a pictorial, simply put, what we do is that we pick up a study population. Then at the beginning, assign some to an intervention. So the upper part, people receive a certain treatment, for instance, and the lower side, there are people who will not receive the treatment, so they are called the control. So there are two arms, typically. So an intervention arm, the upper one, and a control arm, the lower one. Follow them up for a pre-specified period, and at the end of the period, you're figuring out who has the outcome, who doesn't in each arm, and compare the outcome between the two arms. So basically, you're trying to figure out, is the outcome of interest more in the treatment arm versus the control arm, or it isn't? And make a study conclusion based on that. Let me go a little bit deeper into that. If you get this, it's good enough. Let me go a little bit deeper. So just like I've shown you, the commonest pathway is to have two arms, an intervention arm, a control arm. So the intervention arm will receive the investigational product or the intervention of interest. The control arm goes by standard of care, or in some instances will receive a placebo. Now, that's the commonest, that they occur at the same time and you follow them up for the same period of time, and it's the easiest to perform. But there are many, many modifications to this that you can make. Let me give you some. So one, you can have a single arm trial. A single arm trial means that everyone who participates in the trial receives the intervention. And there are various reasons that can happen. A good example is one of the things that we're currently doing is a single arm clinical trial that is looking at using a dual therapy for ARVs, for treatment of HIV. And simply the reasoning for that was that there was only one arm that existed before that and would never have a statistical strength to do a two-arm study based on people who could have been eligible for the study. So there are situations you can just do a single arm study, and that's it. Then you compare the before and after. There are situations you can have more than two arms. Say, for instance, you are trying to manage a certain fungal disease with fluconazole, and you're not too sure if you can use fluconazole 200 milligrams, fluconazole 400 milligrams, or fluconazole 800 milligrams, or nothing. So you can have a control arm that does not receive fluconazole, another arm that receives 800 milligrams, 400 milligrams, 200 milligrams, and you have how many arms of the study? 3? 4. Yeah, thanks. At least you are still with me. Then you can even complicate it further and have a crossover design. Now, a crossover design basically means that if you started with two arms, intervention and control, at some point, the people in the intervention will cross over to the control, and the people in the control will cross over to the intervention. So they'll go like a straight line, then switch over and go to the other arm. That's just one simple way of explaining a crossover design. And there are various reasons you would want to do that. You want to compare, is the sequence of events important? You may want to compare, you might want to use the same individual as their own control for the intervention that you're interested in. So you're comparing the same person because the factors within the same person are the same. So there are reasons that you can use a crossover design depending on what you're doing, but that is how we'd do it. And you can even complicate it further. The commonest way of doing your clinical trial is by randomizing people 1-to-1 to either one arm or the other, the intervention or the control. But you can change those ratios for whatever reason. You can have two for every 2 people going to the intervention arm, there's 1 going to the control arm. You can have 1 to 1 to 1. You can have 1 to 2 to 1 to 2, depending on how many arms you have, how many people you want, and what you're trying to study. So again, just showing you that the complexities of the design can become really wide, but let's stick to common things. We used to have a lecturer who used to say, if you're told in the exam there's an animal with white and black stripes, you don't start thinking of a koala or other things that are complicated, especially if you're in Nairobi National Park. So let's keep to the simple one. So why then do we even need to do a clinical trial? I think the main thing is that we always are looking out for an association between the exposure and the outcome. And when we find an association between the exposure and the outcome, there are 2 possibilities. The 2 possibilities when there's an association is that it is true or it is false. As in, it's that simple. It's either true or false. Now, let's go into the false a little. Why will there be an association and it's false? There are 3 major things to consider that you guys know a lot about. It could be random error. As random as winning the lottery, random. It's just random. You just happened to have designed that 1 clinical trial or that 1 study that just randomly found an association, despite everything that you did. It could have been bias, which is more common, and sometimes we even classify confounders as part of bias. Now, RCTs are good because they minimize, especially the end of the bias and confounding. Yeah, so I think this is where I should pause for a minute and hear. What would you guys define bias as? You've talked a lot about bias. I'm actually tired of standing here. I can use this. Oh, yeah, nice. Bias. Nani amesema sister? I had sister.
Okay, bias in this case, I can cite an example. For example, the case of penile shrinking. If I go to the field, maybe I just identify some few individuals without following the due process. That means I've just subjected a bias to what I'm doing. That is an error that already preceded to the study. And in that case, things that could have been controlled before. Yeah, so that is like my personal view. I go there, I collect it, or I can also cook some elements there and say, now I'm subjecting the process to bias.
So that's an example of bias. I'm looking for the definition of bias. That's what I was hearing, sisters.
My opinion of bias is these are perceptions that are likely to influence your objectivity as a researcher.
Okay, I think bias is just being prejudiced against an individual and an idea.
English.
I think bias is an unfair treatment.
I'm looking for sister.
So it's systematic error, basically, which is either built into the study in the way you have designed it, or how you collect the data, or how you even analyze it.
Maybe you should repeat. I don't need to repeat that.
Yeah, so I was saying bias is a systematic error that can be either built in the study by the design, or through the way you collect the data, or through the way you analyze the data.
So it's systematic. I was looking for that word, systematic. Everything that you said, again, is correct. The issue here is that you're doing it systematically. It's built into the whole process. It's not that it just happened. You know, you really had designed nicely, you had all the good intentions, then you just happened to go to the wrong households. Not quite. It's systematic, it's planned, it's what? Yeah, that one. It's just as Vincent has said, it's that something that you did or something about the design is built into the whole process of how the study was conducted, and it is affecting the outcome or the conclusions that you're making. So whether it is in the design, conduct, analysis, and the one that you didn't say is interpretation. We can also have problems with interpretation. You talked about examples of bias. So Cosmas, you gave us one. It was a selection bias. Selection bias. Have you guys heard of selection bias? Someone can say what they heard about selection bias? Like, how would you describe a selection bias? You said the loudest, yes. You look like you knew. You want to say something?
So for example, it was like Jeanette's work, what you are doing. So if you are looking at that study and then specifically you go to an area, you only select individuals already who have that dysfunction, then the study is not going to be representative of, maybe there could be other people outside the complaint area, but you went specifically to the complaint.
So a selection bias is anything that you do that systematically makes the people who participate in the study different from the population that you want to draw the conclusion to, right? Okay, which other types of bias have you guys had? Huh? Recall. Oh yeah, you guys talked about recall, yes.
Recall bias, I think it's the type of bias where one does not have complete recollection of how events occurred in the past, if they're being asked that in a study.
So, inability to remember well what you're trying to ask. And in fact, it becomes a very bad thing when the participants that you have a difference in how much they remember. So if you have a study that is involving people across, say, age 20 to 70, you can imagine if you are asking them, what did you eat last week on Tuesday? The 70-year-old vis-a-vis the 20-year-old. That recall bias is really bad because it affects your conclusion. So that is, you said, a selection, recall, yes.
Interviewer bias, in terms of how the person collecting the data is asking questions, or even how the measurement of some observations.
So interviewer bias. You were whispering a lot.
No, I was trying to add that interviewer bias is all about judgment and propping.
Yeah. So, in fact, can I widen that to not just interviewer, but investigator? Everyone who participates in the study, whether you are the research assistant, the primary investigator, and it's a huge problem. For instance, how many have seen government funding a study? Okay, see, no hands. So there's someone else who's funding a lot of the studies. All the studies I do, none of them has been funded by government. So that means the person funding me has a certain thing they're interested in, right? So you can imagine me who wrote a proposal and told the funder that I'll conduct this study with your drug, for instance, and try this drug on this population. So by the time I'm conducting that study, I'm already thinking this guy gave me money for me to do this study on his drug. So I cannot just quickly go and say this drug is useless, right? So there's a bias that you can have regarding that, investigator bias. Any other biases? Yes. You guys know a lot.
Misinformation bias. Misinformation bias.
Please elaborate.
Not quite sure if I've the right interpretation. This is a kind of bias where maybe the way the interviewer is framing the question is not in the how the question, what the question is really asking. So you might get the right information, but the wrong question. So, I mean, the wrong question to the right.
Okay. So one of the things that happens a lot is that you have multiple people collecting data, and they all are using the same data collection tool, and they're administering the tool. And if you haven't trained them to be identical to each other, you'll have what she's talking about, where again linked to what you had also suggested, but a classification, information bias. So the information that you're getting is systematically different because different interviewers or different research assistants or different investigators are administering the questionnaire or administering your question system differently. So, the same way all of you have done exams in the past, I'm sure. And when you do an essay and it goes to different markers, they do not mark the same, do they? Do they? There are those ones for handwriting bad, ameshatoa marks. There are those ones for quickly read the top and bottom, indicate marks. There are those ones for reading nitty-gritty and noticing spelling mistakes, marks out. So again, it's all around how you do things. Even simple things like taking weight, blood pressure can be different just because there are different people doing it. Any other biases that you can think of?
Maybe I can say surveillance bias, where we restrict our studies to some areas or some group of individuals, and at the expense of other people in the population who can be affected by the same condition.
So also linked to selection bias, there was another hand somewhere. Okay.
Where would you classify conflict of interest?
Conflict of interest. I will answer that. For who?
Attrition bias. Yesterday, Judge Paul talked about attrition, and maybe if you randomize, if you randomize a 1-to-1, and then some other people drops from one arm, leaving the other side, and then it's not balanced. So, attrition.
Thanks, Ricky and Paul, in conjunction with each other.
There will be interpretation bias, where maybe somebody can interpret or only give the positive results and omit the negative.
Okay. Interpretation. I was going to actually talk a little bit about attrition, just out of interest, because it's clinical trials. So sometimes your outcome of interest might be death, and you're intervening, say, with a certain chemotherapeutic agent. But everyone in the intervention arm exits the study or withdraws from the study before they die. So at the end of the day, you say the death rate was the same in the intervention and control, but then more people left the study, withdrew the study from the intervention arm, and perhaps the reason they withdrew is they told the investigator, Aki, these are side effects I cannot stand, right? But that wasn't the primary outcome that you're interested in. So as far as I'm concerned, this study helps, it reduces death rates, but people had been leaving the study. That actually is an attrition bias, for instance, a good example of it. But you guys have listed quite a number. I'm happy with that. In the interest of time, let me go ahead and just show you some of the ones that I had listed there. And the question around conflict of interest. The conflict of interest is most likely going to affect the investigators within the study. I'm guessing that's where the people you're most referring to in terms of conflict of interest. And for me, conflict of interest will end up within the realm of observer bias. Because you're conflicted, and especially a good conflict of interest issue is where the funding for the study was provided by the manufacturer of the product you're studying. And in fact, there is a study we are part of that we are really struggling with that, because not only did the funder provide the study drug, the funder is part of the study. And they're intricately involved in the conduct of the study. So we end up with arguments around, me as the investigator, I'm seeing this is an adverse event. The sponsor says this is not an adverse event of special interest. I'm like, it doesn't matter what you say, it's an adverse event as far as definitions of clinical trials are concerned. So there's a lot of conflict of interest that happens in scenarios where we conduct studies that are sponsored by people who are part of the product. So it's a part of observer bias. Yeah, so how do we minimize bias? Let me just list them because of time. Randomized control trials are really good because randomization in itself starts to limit bias. You can further go into this by blinding, which I'll talk about. I'll talk about the first two. But by design, the use of control groups also is designed to handle bias. The fact that you have another group that is receiving the standard of care and receiving the same intervention in the same way is designed to make some of the biases be minimized. And if you're using standardized procedures, and when you come to clinical trials, we're very, very dogmatic about standard operating procedures. We usually say, what you wrote in the protocol, we don't even go to the spirit of the law. We just say, this is the law. The country is good at deciding this is the constitution, but the spirit of what they said is that IBC can be there. Ask and say, it is written IBC should have 4 people, should have 4 people. You don't start saying, oh, when those 4 people are, whatever. And transparency and disclosure is also important. I didn't mention too much about this, but there's something called publication bias. There's a lot of publication bias that currently is at play, where people only publish positive results. Even journals generally avoid accepting papers that show either non-significant results or negative findings. So there's a publication bias in the sense that the information that you receive as a policymaker, for instance, is only unidirectional. So transparency and disclosure is part of what deals with that, and that's why, for instance, we have registry of clinical trials, and before we start a trial, we register a trial, and whether or not we put out the study is published, you can literally go back to the registry and see, oh, there was a study that was conducted about X and Y, and I've never seen the result, and it ended 5 years ago. The registry includes contacts of investigators, and you can literally contact the investigators and find out why they did not publish the work that they did. I wanted to talk about 2 things, randomization. So randomization, it basically refers to the process of randomly assigning participants to different study arms. In the context of RCTs, that's what randomization is. I know in exams they used to like asking you what's the difference between randomization and random sampling. So randomization in this context is just that process of randomly assigning participants. The easiest way of doing it is by simple randomization, which is by participant level. So the participant comes, is ready to start the study, and they just randomly, it's a toss of a coin, it's the click of a button on the computer. That participant is randomly assigned to either the intervention or control. Nobody has control over it. It's by just natural factors. If you're really interested in balancing the numbers between arms, you can do block randomization. Blocks basically is you define the numbers of blocks. For every 10 participants, 5 should be in the intervention, 5 should be in the control arm, for instance. And every 10 people who come, you can tell that from these 10, 5 will be on this side, 5 will be on the other side. The block randomization sometimes has a problem because if the person who's doing who's in front of the participant can tell that you're doing blocks of 10, they'll know that the 10th participant will receive intervention, will either go to the intervention or the control, and sometimes even the 8th participant, depending on, because you're blocking it by numbers. So sometimes it's not well liked because of that. Stratified randomization is where you use strata like age, gender, BMI, whatever it is that you're interested in to control at design. You use it to decide which study arm someone will come. So you want to balance and make sure that 50% of the males and 50% of the females are in either group, for instance. And there's a new kid, adaptive randomization. It's becoming more and more famous, where you adjust your randomization plan based on pre-specified trial data considerations. And I'll stress on the pre-specified. So basically, for instance, you do not know the true prevalence of a certain thing, the thing that you want to study or the enrollment criteria that you're using. You don't know for sure how many people will have, for instance, one of the trials we're trying to do, we want to enroll people with certain resistant mutations, but we don't truly know how many people will have those mutations at the beginning. So you can take on an adaptive design that says, I assume it is 6% based on the little data that is available. However, if as you start enrolling into the study, you discover the prevalence is 15%, it changes your sampling assumptions. So your sample size can change, and your sampling assumptions can change, and your randomization can change within the adaptive randomization designs. Then, of course, for crossover, as I talked about earlier, one of the ways you can randomize is the order that someone receives, either the intervention or the control. But randomization is not always possible. There are certain scenarios that you cannot truly randomize, and for that, we use a non-randomized design. And if you remember the pyramid of evidence, a non-randomized design is lower than a randomized clinical trial. So it may not be possible. You will have to go with it, and with that, you have less evidence. Lastly, blinding. I'm about to finish, I assure you. Blinding. What is blinding? It is the process of losing sight. Blinding, I haven't come to this side. Assigning a participant to either arm, but the participant does not know which arm they belong to. Any other thoughts around blinding? Removing glasses. Blinding for the shower. Double blinding. Both the investigator and the participant does not know what arm they're on. You wanted to double blind. So removing both sides of the glasses. Any other thoughts about blinding? Anyone heard of triple blinding?
I think it is used in clinical trials to reduce bias in research.
Maybe triple blinding is where now the participant, the interviewer, and maybe whoever is even doing the analysis does not know exactly which group an individual belongs to.
Some of you, Jeanette, I'm ready to release some people back to their sites. They know too much. I mean, as a whole group, you already know blinding in full. I don't have to say much about it, but the beauty of blinding is that, of course, it helps with the question that you're dealing with around bias. One of the easiest ways is to use a placebo. So a placebo is a product that looks exactly like the intervention that is being provided. Let me use a bad example of a placebo so that you understand. So you could have an injection study that people either receive an injection with the treatment and an injection without the treatment. If it's colorless, both normal saline and the intervention might be the same. So the participant does not know if they're being injected normal saline or the real deal. It's very bad if you're getting that done. So ethics does not allow that. So where blinding is not done, you end up having an open label study. And you'll hear a lot about open label randomized control trials. The reasons for open labeling is blinding is expensive in many instances. A placebo costs money, as opposed to not spending any money on the control arm. Secondly, sometimes the intervention, so an injection, you cannot give someone an injection, say for a whole year, that is just saline or water for injection. It's really unethical because you're exposing them to injection safety issue. So meanwhile, a confounder, which is the other thing that we really, yes. Yes. Okay, that's a good question. So how do you blind an analyst so that you have a triple blinded study, for instance? One of the easiest ways I can use just to illustrate, if you have a two-arm study, one is intervention, one is control. You can decide to label one arm A and another one arm B in your data without disclosure of what A and B is. So the analyst will analyze and say, this is the prevalent, this is the effect estimate that I'm getting in arm A, this is the effect estimate I'm getting in arm B, and in comparison, when I do my tests, arm A, this is the hazard ratio, this is the odds, whatever ratio that you have set up to do in comparison between the arms. Then once the analysis is complete and everything is done, we're all happy, we've gotten it, now someone who's a fourth party unmasks and says arm A was actually the control arm, arm B is the intervention arm. So that's one of the easiest ways to do it. Okay. Yeah, so there are certain benefits to blinding, especially when you're discussing, for instance, conflict of interest. Conflict of interest, if the sponsor is part of the study, you'd really want them to be blinded, part of the war we are having. Confounding, so lastly, I'm being a pastor saying lastly 3 times. A confounder is a variable that distorts the relationship between the exposure and the outcome of interest. So basically, by definition, we say that a confounder is independently associated with the outcome and the exposure. So independently means regardless of the exposure and the outcome, it is directly related to both. So one of the easiest things to think about is age, that you can't control too much about in terms of many studies, especially if age is associated with the outcome of interest. So for instance, old people, the older you get, the chances of dying increase. So regardless of whichever study you're doing, is this chemotherapeutic agent better for breast cancer or not? As people age, they will likely die, independent of whether whether they are on a chemotherapeutic agent or not. But at the same time, older people may react badly to the chemotherapeutic agent as compared to younger people. So again, age is independently associated, for instance, in that. So it can make the association stronger, it can make the association weaker. And part of the problem is especially when it makes the association weaker, because then you might find an insignificant result, but it's because the confounder has not been controlled for. So you'd have to control for confounders. The analysts in the room know that there are ways they can do it, and you'll be talking, I think, more about it. But prevention is always better than cure. So if you can control for confounding by design, it provides the best outcome. So if you use certain methods, such as, for instance, randomization, as we've talked about, or matching based on a confounder that you're interested in, like, for instance, the stratification that we're talking about in randomization, it helps in addressing and controlling for confounders. So back to this, which was the most basic slide for the clinical trials. So clinical trials, the best thing is that if you look at the greens and the blues, if you truly randomize at the beginning, the greens and the blues should be equally distributed or close to equally distributed between the two study arms, if you're truly random. And if that doesn't happen, there are some reasons for it, and one of it being that for instance, your sample size is wrong. But one of the things that we have learned from experience is that if you have a variable that does not obey this, you have truly randomized well. That sounds conflicting with everything that I've said. It's interesting that for the trials that we have done, one of the things that we've noticed is that when you do that baseline table and just look at the BMIs truly split between the two arms, you always find that one thing that just does not obey the rules. Either it is cigarette smoking, it is level of education. There's always something down there in the tables. So if you have that, and I'm giving you a hint of critical appraisals of papers, if you have a difference at baseline on one of the two minor factors that were never controlled, that's a good sign. These people are being truthful. If everything is perfectly, like 50-50 between the study arms throughout, start raising your antennas. It's very hard when you have 20 or 30 variables to be split equally amongst study arms for them to be perfectly distributed for 30 variables. But that one is something that we picked on the go. But by design, what we assume is that it will be 50-50 distributed. And what we look out for especially are the known large confounders, likely confounders of the relationship between the exposure and outcome. I will leave this up and ask if there are any questions. Yes.
In the single basically, I was wondering how now randomization happens, yet it is just a single arm. And if therefore no randomization happens, does that mean that quasi-experiment will fit that single arm?
Yes, so single arm by definition means there's no randomization because everyone goes into one arm. So if there's no randomization, yes, you can think of it as a quasi-experimental design in some way. But again, just to say that sometimes you're pushed to a corner where single arm is the only way to go. You can, for instance, think of a clinical trial on Mpox. Mpox, currently we don't have much information about, and then someone comes and says, I'm the president of the US and I think ivermectin can work. Anyway, I'm joking about ivermectin. So if ivermectin is safe and is something that, you have no other intervention for Mpox by definition, and then you say, let me try ivermectin, then for ethical reasons, if there's something that might work and is in a hopeless situation, you might choose a single arm. You might want to, anyone who agrees goes on treatment with this. And you compare that with what we know would have happened for everyone who didn't. So there are ethical reasons, for instance, that you'll use a single arm study. And as much as it's not as strong as your randomized control trial, it still generates very useful information that policymakers and all of us in science will be interested in still finding out, because we know the realities are that we cannot have an intervention that can be equally split between different groups.
So if we can have a single arm in clinical trials, and then is it possible to have a single cohort in cohort studies? For instance, we are following up a single group which has the same exposures so that we can assess maybe time to event.
So yes, almost by definition, by convention, cohort studies will be like a single cohort being followed up for a period of time. Not all of them will have the exposure by definition. So you're actually trying to figure out those with exposure, those without exposure over time, what happens. So the cohort study is a singular arm, if you want to look at it that way.
In simple randomization, how do we ensure we have equal number per arm? Or can one arm be more than the other arm?
That's a good question of bulk randomization versus simple randomization. I said people do bulk randomization so that you can have the perfect balance. The reason is simple randomization. Remember, it's the easiest way to do simple randomization, like we're taught in school, is tossing a coin. If you toss a coin, after we assume that after you toss the coin enough times, that was the rule in maths, that ultimately you'd get the same proportions of people in one arm versus the other. But that number will not be identical. So for instance, if you're interested in enrolling 800 people in a trial, and you're tossing a coin, at the 800th person, it's unlikely, and we'll actually question you, if at the 800th person, you are at 400. Someone will actually come and test your process to figure out, did you truly do simple randomization? Because simple randomization is at the individual level. So what you will see is that for clinical trials that people want to use simple randomization, they say that my target is to enroll at least 400 people in each study arm. So the aim is to get to 400 in each arm. So at the end you'll see some papers where when they tell you they enrolled, when they do how many people they enrolled per study arm, you'll see a difference between arm A and arm B. A difference of 1, 2, 3, 5 people. And that's because they're waiting until each arm gets to the minimum that was calculated from your statistical processes, your sample calculation. So it's not perfect for simple randomization. However, there are reasons why we try to get to the perfect, and that's mainly budgetary and mainly related to other aspects of clinical trials, such as having to get clinical trial insurance that you pay per participant, and the other considerations that make bulk randomization be the preferred method that people use and get that perfection that you see.
You spoke about the crossover aspect of the clinical trial, and I didn't get it clearly, and requesting if you could repeat it with an example.
Okay. Crossover. There used to be a show on TV called Crossover. Sorry, I'm using that to get to the mic. So crossover study design. Let me use a simple illustration to try and show that. So you have 500 participants in a trial at time 0. Let me use this time 0. So that 250 go into the arm A, which is the intervention. 250 go into arm B, which is the control. So you wanted me to use an example. Let's think of different antibiotics to treat syphilis. Oh no, gonorrhea. Okay, so because gonorrhea had a superbug recently. So if you are treating gonorrhea, the standard of treatment, I don't know what it is. So suppose this is ciprofloxacin, and you're trying a new drug, a new quinolone. Which is the newest quinolone, people, for antibiotics? Okay, that newest quinolone. So there's one quinolone here, one quinolone here. You're trying to figure out which, gonorrhea is a bad example, but anyway, treatment for whatever reason. So what happens is you define a time period, say 2 weeks, because we're dealing with a small issue or short duration of treatment. Then you want these people to cross over to this side, and you want people to cross over to this side. So this one in B, all the 250 go here, and all the 250 go here. Usually there is a period in between that is allowed. You can have a period, say, in our case, let's give it 1 month. That is called a washout period. Let me explain this a little bit better. Okay. So let me use a better example. So hypertension, which must be treated, you say that the gold standard of hypertension, for instance, is HCTZ. You give 250 people HCTZ, and 250 people, you give them a new antihypertensive drug called Joseph. So these people who receive Joseph, you check their blood pressure for a period of 2 weeks. These ones who receive this one, check a period of 2 weeks. Then somewhere after the 2 weeks, take them off drugs, so that any long-acting effect of Joseph is worn out, any long effect of HCTZ is worn out. Then these ones who receive Joseph go to HCTZ, and these ones who receive HCTZ receive Joseph. And then you follow them up for another 2 weeks, then you compare the results. Now, what happens is, in this analysis, because everyone received B and A, you will actually compare per person what the effect of the new drug vis-a-vis the old drug is for that same person. So they act as their own controls. I don't know if that makes sense. Yeah. Wow. How much more time do I have? I take these 2 questions. Okay. Okay.
Okay, thank you. So, you've talked about the need to balance various factors when carrying out an RCT. So my question would be, how practical or feasible would it be to take a step-wedge approach, the step-wedge design in an RCT? How practical would it be within our current scope, and would it kind of complement and kind of help balance some of the issues you were talking about?
So you're going into very complicated designs. The more complex a design is, the more time it takes, the more money it takes. So that's a main problem with anything that you try. And the other problem, I'll say it's not written in books, overmatching causes problems. Over-controlling things causes more problems. Whenever you're looking for perfection, you discover how far from perfection you always get. So that's another consideration to always have.
Thank you. My question is on controls. Are controls not supposed to be known values? Like, for instance, if you are doing something, maybe you're testing out, maybe for say the way you were testing for hypertension and you're looking for the drug that was working, are you supposed not to test it against known controls of the working period?
Okay. Yeah, so that's another interesting question. So for clinical trials, we always start with something called equipoise. We don't know for sure if something works. And part of the reason we do not know is that even what we know as control and standard of care might be changing over time. There might be building resistance, there might be climate change factors that make what we know as controls change the reality today as opposed to what it was yesterday. So when we do clinical trials, we actually follow up controls with the assumption that there's a background factor that affects how people will react to the control. Whatever disease you're thinking about, whatever outcomes you're thinking about, things change over time. There's always that assumption. So the control is not a static thing. So it's part of the problem with the single arm study design. If I go back there, there's always a confounder called time. And that time confounder means that things change with time. Yes, thank you so much. I will answer the rest of the questions over lunch.